Welcome everyone to today's Grand Rounds. We have the pleasure of having Dr. Wilson Szeto from UPenn presenting today. Before we get started, I just want to go over some housekeeping items. First of all, if you are submitting questions, please use the Q&A feature on the system rather than the chat, and we'll address these at the end of the presentation. You can also submit live questions at the end of the presentation using the raise hand or the hand up feature, and we'll unmute you when that happens. And if you're having any technical difficulties, please use the chat feature to send a message. So before we start, I just want to introduce our esteemed speaker today. Dr. Szeto is the professor of surgery in the Division of Cardiovascular Surgery at the University of Pennsylvania School of Medicine. He currently serves as the chief of cardiovascular surgery at Penn Presbyterian Medical Center of the UPenn Health System. His clinical practice spans the entire field of adult cardiac surgery, but his clinical interests really involve the treatment of thoracic aortic pathology and complex structural and valvular heart disease. His expertise encompasses the full spectrum of interventional strategies ranging from complex open heart surgery to the latest techniques in transcatheter and endovascular therapies. At the UPenn, Dr. Szeto remains extensively engaged in clinical research as well as the education of thoracic surgical residents. He's been active in multiple clinical trials for both endovascular stent graft therapies for thoracic aortic pathology, as well as transcatheter therapies for valvular heart disease. From an education perspective, he's been involved with the development of an advanced and integrated training program that emphasizes the integration of catheter-based interventional skills and conventional cardiovascular surgery, preparing surgeons for the cutting-edge techniques of the future. On a personal note, I would say that the Ottawa Heart Institute has had a number of useful and very productive collaborations with UPenn, including the North American Aortic Valve Repair Symposium that we jointly host, for which the next or the fifth edition will be in September of 2022. The UPenn team is also participants in our Titan surgery versus surveillance randomized controlled trial, and we'll be sending one of their trainees for coronary surgery advanced fellowship to Ottawa in the coming months. So there are multiple fruitful collaborations with the UPenn system, and we're really delighted to have Dr. Szeto talk to us today about management of the aortic arch, the current landscape, and future innovations. So with that, I'll hand it over to you, Wilson.
Thank you, everyone, and Munir and Mark, thank you for the tremendous privilege and pleasure and invitation to speak today at Grand Rounds for your incredibly successful institution. So it is absolutely a pleasure for me to be here this morning. And thank you for the kind words about UPenn. And I really have treasured and I look forward to future collaborations between our two institutions. It is absolutely just a lot of fun to be able to exchange great ideas and hopefully make a huge impact in our field as we move forward. So thank you. So as Munir stated, I was asked today to speak at Grand Rounds, and one of the topics that I have had a lot of interest in over the last 15 to 20 years is thoracic aortic surgery. And I'm going to focus today on the aortic arch, a brief summary of where we have been, where we currently are, and perhaps provide a snapshot into what the future may look like in terms of innovations as we try to continue to improve the care of our patients. And would love to have a nice exchange of conversations on what the excitement and what the future will be. So here are my disclosures. So as all of you know, this is a complex and challenging clinical scenario, extensive thoracic aortic aneurysm. So to put things into a clinical context, what are our options in 2022 now? And the reason the reason all of us have this tremendous interest in this area is we all know that our population is getting older. This is an older study out of Europe, but we have had signals now for at least a decade or two understanding that our population is getting older, and predominantly aortic aneurysm disease is degenerative and is in the elderly. And not only are we seeing aneurysmal disease, but also dissections and et cetera, et cetera. We also know that over the last 2 decades, innovation has really taken off. And I really do believe it's just the tip of the iceberg. At Penn, we were fortunate enough to be part of some of the early innovations and was part of the ground floor with many other centers in leading the field, not only in open aortic surgery, but hybrid or catheter-based or endovascular surgery. And we were able to convince our colleagues here at Penn, or administrative colleagues, to invest heavily into these technologies where we can do these hybrid procedures, i.e. hybrid ORs. And dating as early as the early 2000s, we were beginning to construct and help lead and shape the field in terms of endovascular hybrid ORs. And I think that's important. Also, from my mentors here at Penn, one thing I learned very early on as a trainee is the concept of a team approach. We hear a lot about that now in structural heart, but to be frank and respectful, here at Penn, we have really embraced this concept very early on. In the 90s, when I was in training here, we already had a very robust, comprehensive team approach to aortic surgery. And I think that culture at that point was very, very unique and have really allowed us to be successful. And it is, and that group continues to increase, not only surgeons, both cardiac and vascular, but our cardiology colleagues, anesthesiologists, neurologists, perfusionists. You see the list. It really is a all hands on deck, a team approach. And just a little shout out to our industry partners. We really do view them as colleagues in terms of advancing the field and improving the care of our patients. Now, in terms of what we have done in the past, I think all of you are aware of the complexity and the technical challenges of conventional open heart surgery. You can see on the right-hand side of the screen, an artist rendition of, I think what most of you in the audience understand and have done in the past, a total, complete open heart reconstruction. But as I've stated, even though I think we do a good job now in the 2020s, it is still technically demanding. It requires complex circulatory management, oftentimes hypothermic circulatory arrest, and the morbidity and mortality may be significant, especially in high-risk patients. And I'll address this a little bit in terms of the whole concept of unmet needs. Here are some sort of conventional historic series to sort of get us going and give us a context and a benchmark of what we should be thinking about. You can see here many, busy centers, Mayo Clinic, centers in Texas, Japanese, European series. Some of the early publications demonstrated that we can do it safely and we can do it well. But as I mentioned, it is still an operation in the best of hands associated with some risk of both stroke and mortality. When we talk about extensive arch aneurysms, like the one I've depicted earlier, these are even more challenging, not just the proximal aneurysms, but the ones that involve the arch and perhaps proximal descending thoracic aortic disease. There have been a few approaches. This is something that's been championed by Dr. Kachukis, one of our early leaders in thoracic aortic surgery, a single stage approach, the clamshell or thoracal sternotomy. Boy, this is a big operation and is really not for every patient or every surgeon. And as you can imagine, a significant amount of both surgeon as well as patient selection bias. Many of us have gone to now a two-stage approach, and even that approach now has evolved. But this is one of the earlier series with Joe Caselli's group in Texas, providing an approach that is two-stage, a proximal arch reconstruction with an elephant trunk, and a complete second stage open thoracal abdominal reconstruction. But as many of you know, these are very, very large, extensive operations. And that being one disadvantage, but also the interval variability, the recovery and the time between the first and the second stage can be quite variable and perhaps associated with its own set of mortalities. Here are some series, again, from early leaders in the field. You can see here, Dr. Greep out of New York, the Texas group, Dr. Swenson out of Cleveland Clinic, Europeans as well, demonstrating that although it could be done safely with good outcomes, the risk remains significant in terms of both not only the first stage, but also the second stage, not to mention oftentimes an unreported or not much appreciated interval mortality. This is a case that I took care of probably about 5 years ago, and it really at that point made the point to me that despite what we've accomplished, there needs to be more thought and work to be done. This is a 77-year-old gentleman. I'm going to let this CT run again. He presented with an extremis, basically with a rupture arch. You can see that with a large pericardial as well as a pleural effusion or hemothorax. Despite 77, obviously this would be a big operation. At that point, not a whole lot of endovascular approach in this area. No past medical history, and was very healthy, active, and in fact, a avid runner. He was one of those quote unquote good 77-year-olds. We took him in the operating room, did a extensive arch operation, did a frozen elephant trunk under circulatory arrest, and you can see here the end product on the right-hand side. And here is the completion thoracic CT scan. He did okay. As you can see here, it extubated on day 3, no stroke, and he finally went home on day 17. And if you look at all the publication in the literature, for all intents and purposes, this case would have been checked as a success. No stroke, no mortality, but it doesn't tell the full story. Putting on the patient's hat, this is what happened to him, and these are the factors that oftentimes do not make it into a surgical literature to give us a complete picture. He had vocal cord paralysis because of a rupture. He needed a feeding tube. So subsequent to that, he had an ulcer requiring a laparotomy. He was very debilitated and deconditioned and some element of depression. He couldn't run like he used to run. And he had a long rehab course. He's doing well. He's still alive now 5 years later. But this really has changed him. So in my mind, despite all the advances we've made in open surgery, and yes, we can get these patients through the operation, I do think there is an unmet need, and there's still an opportunity to move the field forward. Because as a patient, if I were to put on a patient's hat, or if this was my father, I would like to think that in the near future, there may be better options for a 77-year-old who presents in this condition. So early on, with the advent of thoracic endovascular aortic repair, or TVAR, when it was approved in the mid-2000s, we started at Penn to think about how we can marriage what we know with conventional surgery, taking these new technologies and asking interesting but difficult questions. Can we do it better? And this was one of our very early experiences. It was presented at the Aortic Surgeon Symposium back in 2006 when I was a young faculty. Very early experience, all saccular aneurysms, all 8 of them. They did well, but these were truly patients that we felt were inoperable or prohibitive risks. Since then, we've built on that and using this platform to address more and more aggressive and more complex anatomy, to proceed with just what we call simple type 1 repair, where we're just debranching the arch, doing everything potentially off pump, to now more extensive aneurysms, such as the one you saw in the 77-year-old, a type 2, where you have to reconstruct the ascending aorta for proximal landing zone and a concomitant stent graft placement to address the arch and distal proximal DTA, to now even more extensive, what we call type 3s, where you have to construct not only an entire ascending aorta in the arch, but also extensive disease down into the remaining descending thoracic aorta. And these were now just the beginnings of a new era and a new culture, a new way of thinking of how we're addressing aortic pathology, leveraging not only what we know with open surgery, but also now with this new tool, endovascular aortic repair. Here's some of our early data and series and experience at the University of Pennsylvania. We published this in just almost a decade ago in 2013. Again, put it into context, these were patients we felt were not ideal or prohibitive risk for open surgery. You can see the smattering here in the demographics. These are truly elderly patients that have multiple comorbidities. Here are some of the intraoperative variables. These are open operations. These are not complete endovascular approaches, which I'm going to touch on later, which is where the exciting technology in field is going. But these are still open surgeries. But with the advent and able to leverage endovascular approach, we're hoping sort of to minimize that first stage in terms of minimizing the physiologic insult, a shorter clamp time, shorter circle rest time. And the outcomes here were reasonable. They were something that was acceptable given the high-risk nature of these population of patients. Still, however, mirroring what we've done conventionally in less high-risk operations that you saw earlier in some of these series. Strokes and mortality in the high single digits. So comparable, again, in the context of sicker or higher risk or more elderly patients. And as you can see here demonstrated in their 5-year midterm survival, these are patients with comorbidities. Despite getting them through the operation, long-term outcomes remain to be determined, investigated, and followed. Now, in terms of the arch, another area of active investigation is how we manage the aortic arch in the setting of a proximal aortic dissection, type A or DeBakey 1. So we're transitioning a little bit about aneurysmal disease, but talking about the arch in a dissection in a more urgent fashion. And at the end, I'm going to sort of bring all this together and where the field's going in terms of how we manage the arch. You've heard these discussions before. The traditional operation of dissection have been very well published and investigated. There are multiple components of a dissection repair. Obviously, you have to address the proximal aorta where the primary artery is. There have been multiple discussions in investigation, a lot led by Dr. Bodwani here about how we manage the root, how do we repair these valves. But I'm going to focus a little bit on how we manage the arch. Traditionally, we've done hemiarches, but now there's questions about, is there more we can do in terms of the arch and preparing the distal aorta for future aortic related events? And how do you select the right patients? I mean, does everybody get a hemiarch? Does everybody get an extended arch? And what are some signals in terms of durability, long-term aortic reintervention rates? And how do you find that sweet spot in terms of doing the right operation for the right patient? A little bit background. This is an interesting paper I came along and had really had a chance to reflect on this. This is a STS adult cardiac surgery database paper published in 2018. And I think this tells you and summarizes a lot of the challenges that we have with aortic dissection management, at least in North America. This is a series you can see here, just 1 year, a snapshot, but a fair amount of patients, almost 3,000 patients in 640 centers. Similar to some of the large series IRAD database, for example, operative mortality, 17%, stroke, just under 11%. In terms of the cannulation technique, you can see here quite a bit of variability. The database at that point was not granular enough to let us know what the strategy was in terms of treating the arch. But I think the take-home message here out of this snapshot is the following. The median cases per year per center, not per surgeon, but per center, is 3 cases. These are emergent cases that oftentimes cannot be referred due to clinical reasons to a center of excellence. So how do we think about helping our patients, and obviously more important, just as important, helping our surgical colleagues to be able to do an operation that best fits our patient's needs and do a good job? And if we use the metrics, and again, quite arbitrary, but if we use the metric that 10 or more cases per year is considered a high volume center, only a minority, just above 10%, would meet that criteria of a center of excellence with high volume. So something to think about and digest and think about how this is a very interesting yet challenging scenario for us as a specialty. Here at Penn, we started off with a lot of work with hemiarches. We were fortunate to be part of some of the early leaders in trying to figure out what the best way it is to address the arch. This is still, to be honest with you, one of a more routine or go-to operations. It's a very good operation. It's got long-term outcomes that everyone's comfortable with. You can see here, this is a publication that was by our group a few years ago, demonstrating that in the right hands, in the right patient, this is a very good operation. Aggressive hemiarch in almost over 500 patients with type A aortic dissections. You can see here freedom from distant aortic reinvention at 10 years, hovering between 85 and 90%. Survival remains around 50% long-term, hence another area of discussion about what we can do perhaps at the index operation to help us extend and move that survival curve. But as I mentioned, there have been a lot of discussions about, is there something else we can do at the time of the index operation, with caution and judgment, of course, to perhaps move the needle and impact distal aortic reintervention or events. And this has been an area of hot topic and discussion. Here is a recent meta-analysis out of Asia looking at some signals that I don't think would surprise any of you on this conference or grand rounds. Early mortality, some signals would perhaps suggest a favor towards a less operation, because obviously the bigger operation, the more potential for operative morbidity and mortality. But as you can see here, as you get out into the later benchmarks and looking at downstream problems, perhaps an extended repair may provide some benefit. But again, clinical judgment is of paramount here, because as many of you have heard from multiple investigators, you still have to get through the first step, meaning get the patient through the operation before you can look at downstream and long-term outcomes, right? So a little bit of a balancing act here, but it gives you a flavor that perhaps all of us would understand at this point, that a strategy that you can sort of walk the fine line and without compromising early mortality, but able to have an impact on later events or later mortality would be the ideal sweet spot and ideal procedure. And as I mentioned before, now the field has really extended, and we're going to talk about this in a little bit, but what we can do now in an extended fashion, whether it's a zone 3 total arch, a hemiarch with an elephant trunk, frozen elephant trunk, as I demonstrated in a case earlier, hybrid approaches. And then we're now starting to have some idea of what these indications are. As I laid out here, tear in the arch, distal arch aneurysms, distal malperfusion, an area of hot topic in a retrograde type aortic dissections. At Penn, in the past, we have also expanded on this as well, looking at our experience with a concomitant integrate stent grafting at the time of the index operation of the DeBakey-1. There are now some signals to promote that perhaps that technique not only improves survival, but promote distal aortic remodeling and reduce distal reoperation rate in the future. And this has led to really a field that is moving. And I've been very proud and honored to be part of this recent consensus document out of AATS under the leadership of Dr. Malazri. This is just one piece of the document, but specifically about aortic arch management. As I stated earlier, there's now a field that is now moving towards having a better understanding what we can and or should not do, what we can and cannot do, or what we should or should not do at the time of the index operation in terms of the arch management. There is now accumulating data to give us some guidance in terms of when we should consider a more extended operation. So let's talk about the future. And I think this is where a little bit is very, very exciting. I want to spend the remaining part of my discussion here to share with you some of the work that I've been very fortunate to be part of, innovation piece. And I think these innovations have a couple of potential consequences. One, to continue to improve the way we do the operations currently, but also think outside the box and think about how we can do operations that are quite different, specifically a total endovascular arch repair. Many of you are aware, and some of you may also have access to this in the United States. The only device that we are currently having available is the FluoroFlex. That was just recently approved a few weeks ago by the FDA. So that's very, very exciting. Here in the United States, we're going to start to have access to some of these devices. I know in Canada, you guys have had access to some of these devices. So we're quite jealous of you guys in terms of having access to these new toys. As I mentioned before, we really have evolved in terms of how we do an elephant trunk. Traditionally, it was described as a conventional two-stage open repair. Open proximal operation with an arch, followed by an open distal repair. We have now gone to a hybrid approach, as I have stated or described, where that second procedure could be an endovascular approach, reducing then the morbidity and mortality of that second operation. And as we evolve with these new devices now, perhaps we can do this as a single stage, continue to move that needle in terms of not only outcomes, but also minimizing that physiological assault to our patients. This is a device that is interesting. I'm excited to get my hands on this, hopefully in the next few months. It is a hybrid device in the sense that your proximal portion, which is, you can see here, the arch, the ascending arch procedure is your traditional standard conventional Dacron graft with a stented DTA or distal component to treat the distal thoracic aorta. So again, now really mirroring and marrying some of the work we did early on with hybrid surgery, providing us surgeons with another tool that's specifically designed to be used, as opposed to something that we got creative with on the back table. This is another picture of the device. I'm not going to get too much into this, other than that this is another tool to allow us to facilitate a treatment and perhaps give our patients a better outcome. Just to share some of the data that led to the FDA approval, this was an interim report by Dr. Caselli back in 2019. He presented this at the American Association of Thoracic Surgery in Toronto in May 2019. This was the study that has led to FDA approval, prospective multi-center open label single arm study, primary aneurysm group with a dissection group as well, and also an additional more high-risk group of patients with rupture of the thoracic aorta. In terms of the inclusion criteria, acute dissections, chronic dissection, aortic aneurysms, as you can imagine what this really is designed for. In the high-risk rupture group, true rupture was the inclusion, or high risk of an imminent rupture with the judgment of the treating aortic team. Just to share with you some data, permanent stroke, as well as paraplegia, aortic-related reoperation and mortality, obviously centers of excellence. These are all very, very encouraging outcomes that obviously have led to FDA approval. It's mid to low single-digit outcomes in terms of and the risk of morbidity and mortality. So very, very exciting. This is another device that I wanted to talk a little bit about, and I think many of my Canadian colleagues, again, this is where the jealousy part comes from me, that you have had access to this for a few years now. In the United States, we're moving towards a study in the United States. It's a privilege for me to lead this trial in the United States. This is the AMDS, or Osiris medical dissection stent. It is for the treatment of DeBakey type 1. This fosters and leverages the knowledge that we've known in the management of type B dissections. So again, cross-fertilization and sharing knowledge with our vascular colleagues. You know, the whole concept of a stabilized or stable concept that we've demonstrated with type B aortic dissection stent grafting. For example, a cover stent in the proximal DTA with bare stents across the visceral segment. With that technique, we've demonstrated positive aortic remodeling and minimizing distal aortic reoperation. We have taken that concept, working with the inventor of this device, and you can see here, combining again our knowledge of what we could do proximally, an open proximal limited arch reconstruction, i.e. a hemiarch, with a concomitant placement of this bare stent across the arch over the arch vessels, with the idea or the notion that this could remodel and stabilize the arch in the proximal descending thoracic aorta. Concept similar, as I mentioned, to stabilizing the abdomen, but certainly a new concept and a new tool in the chest for us cardiac surgeons. I think this is a germane point here in terms of the simplicity, as opposed to the Thoraflex device where you have to be comfortable doing a total arch. This is I think a device that could be applicable and helpful to all surgeons. Back to the slide of the type A dissection snapshot, where most centers do 3 procedures or less a year. I think this becomes a very powerful tool. Standard hemiarch and a concomitant deployment and a bare stent across the arch. You can see here is the device, a felt portion proximally to help with the anastomosis, followed by an uncovered nitinol stent for across the arch. And you can see here is an artist's rendition of how you can imagine cardiac surgeons, not experts in aortic arch surgery, but cardiac surgeons could very well help our patients with this tool in their hands. I'm going to show you a video. Demonstrating how this can be deployed. And I really do think this will make a tremendous amount of impact in our field, based on what I've just shared with you earlier with incidents and how urgent these operations are. These are not elective arch aneurysm cases. You can see here in the video, a proximal tear in zone 0. All of you are familiar with the anatomy and physiology of a DeBakey 1 dissection. A standard hemiarch or open distal operation is performed. You can see here, the device is deployed in a way that is actually quite intuitive. Slight modification of what we do. A 1 centimeter of residual distal ascending aorta is required to be left for anastomotic technique. But as you can see here, under direct vision during circulatory rest, this device is deployed into grade. This is then reinforced to provide any distal entry tears. An essentially open distal anastomosis in the distal ascending aorta. Deployment of this device. Under direct vision, under circulatory arrest. Again, this is a bare stent, so it does not compromise or occlude the arch vessels. Reinforced, again, to prevent any distal aortic new entry tears, and your standard open distal or hemiarch reconstruction. I think most surgeons, inclusive of all backgrounds, so this is a very inclusive, all-comers technique. I think this technology will make an impact across our entire cardiac surgical community to allow us to provide care for these really sick and acute group of patients with high acuity. Now, in terms of the outcomes, these are results from the DARTS-1 trial, Canadian surgeons led by Canadian groups. You can see here, very, very encouraging data in terms of remodeling the arch. You can see here, comparing the standard, which is just a hemiarch, versus the AMDS device, hybrid device on the right-hand side. Much, much higher rate of remodeling in the arch healing, and then also descending thoracic aorta remodeling. So we're excited that we're going to have an opportunity here to see how we fare. We hope we fare as well as our Canadian colleagues. And we're really looking forward to the studies to start, hopefully within the next month or so here in the United States. And the study will be on focusing on malperfusion, because that group is the group that has the, I think all of us know, has the highest impact in terms of just poor outcome. I'm going to get through this pretty quickly. All of you are familiar with the Penn classification. It is not an anatomical presentation. It is a sort of physiologic or clinical presentation or clinical classification. It's really a classification of the severity of malperfusion. As all of you know, the more organs and more extremis and more malperfusion that you present with, the higher the risk of mortality and morbidity. And with this study using the AMDS, we're really going to focus on using this device in patients with malperfusion. So I'm going to finish with now in the next few minutes, so we have some time for discussion. This is the area of the space that I'm really, really excited about. And that is now, how do we move from a traditional open to a hybrid to now an endovascular approach to addressing the arch? And I'm not here to tell you that endovascular approaches is going to completely eliminate the other two techniques. I really do think this is synergistic, and it's all going to work together. And these are all going to be important tools in the toolbox of a cardio-aortic specialist. So this is where it's really exciting. These are some of the devices that are currently in investigation. None of these, at least in the United States, are available commercially. Most of these are still under trial or physician IDE, so very limited. But I'm very, very excited to share some of the outcomes so far. Now, the arch stent grafting is not a new concept. This is Dr. Chuter's group with a modular branch device published as early 2000 in Journal of Vascular Surgery. So the concept has been around for a while. This is the Cook double branch device. Dr. Holland's group in Europe and France led the way here. You can see here, these are some of the early series. Granted, take this into context that most of these were patients that were deemed to be either high risk or felt to be inoperable for open surgery. Mortality rate and stroke rates are concerns, specifically stroke. We're going to talk about that a little bit. And of course, like any new procedure, there appears to be a learning curve. This is the branch device from Gore. This is a single branch device. It's a device that's ongoing in the United States in terms of investigation. It's a flexible and nimble device in the sense that because it's single branch, it could be used to address as a single branch in the left subclavian or zone 2, zone 3 pathology. Or if you need to get more proximal, it could be a device deployed in zone 0 with a single branch in a nominate artery. Of course, that will require an extra anatomical double arch bypass. But again, moving in that direction of an arch approach with endovascular devices. This is another device that's ongoing that's currently being investigated here in the United States. This is the Nexus device, the TRIUMPH study from Artivion, also a single branch device with a modular design. Again, currently in the United States as a IDE study. Early on, enrollment is accruing, so more to come on this, hopefully in the next year or so. This is the device that I have had the most experience with. This is the Terumo Relay Dual Branch device. It's in many ways in concept similar to Cook devices, but there are some technological features that have been advanced. You can see here is a conformable device to the arch, has 2 antegrade tunnels. It has a very controlled, precise delivering system to allow us to navigate the arch. So learning and building on knowledge and foundation from what we've accomplished and accumulated over the last 5 to 10 years. In terms of the procedure, I think it's fairly intuitive. You start with a left subclavian bypass, extra anatomical. This is followed by a main body deployment. You can see the large window with the 2 tunnels. So the window will then guide your deployment into those tunnels, followed by single branch into the brachiocephalic or the nominate artery via a cut down the neck retrograde approach, and then similar to the left common carotid. So no sternotomy, no circ arrest, no going on pump with some neck incisions, but in one simple extra-anomacal bypass. So this is something that we've been now doing at Penn as part of a multi-center early feasibility study in the United States over the last 5 years. This is not a new device. This is a device that has a lot of experience in the world. You can see here, OUS experience is extensive. The double branch, 400 patients have been treated through the custom program in Europe, Canada, and Asia. In the United States, we're almost done with our EFS of 30 patients. We're in the process of discussing with the FDA about next steps. Whether we extend the EFS or go to an IDE, more to come. And the triple branch. So building on the knowledge, we're now moving towards a complete endovascular retrograde from the groin, a triple branch device. And that's been now treated in 4 patients in the United States through a compassionate use program. Just some European data here. Our colleagues, again, leaders in this, this is Dr. Cherney's group. Again, high-risk group of patients, elderly, comorbidities that you would expect. Early results that are very, very promising. Low risk of endoleak, very low risk of mortality and disabling stroke, very high technical success rate. And as I mentioned, there's currently an ongoing EFS study in the United States. More to come on this. And I just want to share with you, this is one of our early cases that we performed at Penn. And I think this will kind of put everything into perspective, what a huge innovation this potential could be. This pathology is very similar to that 77-year-old gentleman that I demonstrated earlier with a rupture. This was not a rupture, but you can imagine if this technology were to mature, this would be an excellent potential tool to treat these patients. I'll let the video run through. Again, conduct of operation, fairly intuitive and straightforward. At this point, 3 cut downs, 1 in the groin for the main device, 2 in the neck. But you can imagine how that eventually could either be percutaneous or retrograde from the groin. This is the main body deployment. You can see how the device nicely conforms to the arch. It is well marked. You can see windows. You can see where the tunnel is. We line this up with the arch vessels. Very easy to visualize. Under rapid pacing, much like knowledge that we've learned from TAVR, a lot of, again, cross-fertilization of knowledge here. The device is then deployed. You can see the markers of the window. At this point, the arch vessels remain open, not covered. This large window allows the arch vessels continue to be perfused. There's no ischemia time. This is real time. This is a cardiac surgeon, me, engaging this tunnel in a retrograde fashion. So you can imagine that if I could do it in this period of matter of seconds in a real time, that this is a device that's designed for someone that can really engage and do these procedures in a very efficient way. The balloon is then dilated to confirm that the wire is in the tunnel. An angiogram is taken to make sure that we know exactly where the bifurcation of the right subclavian and right carotid is, so we don't cover it and encroach on it. This device is then brought into the tunnel over a wire in a retrograde fashion and deployed. Balloon at the junction. And then the same is performed on the contralateral side, the left common carotid. Again, balloon test is performed to make sure we're in the proper tunnel. The device is then deployed. Delivering system is retracted. Ballooning at the junction. Again, a very intuitive procedure, and for surgeons comfortable and have done a lot of endovascular work, each step is something that they've done before. Perhaps not all together in one procedure, but certainly new technique that's a new skill for individual to learn. Here is the completion CT scan with showing completion, demonstrating exclusion of the aneurysmal sac. This procedure, this case was done 4 or 5 years ago, and she remains a patient that I follow. She's doing extremely well. And you can see here, really exciting technology. And extending and kind of now wrapping the whole story together, this is a procedure with an expanded indication. This could be a rescue therapy as we think about, as we do a proximal operation for DeBakey-1. This is a patient that had a type A dissection repair years ago with an ascending hemiarch that has now developed a distal aortic aneurysm from his residual type B. We were able to treat this patient with this current EFS study, where we're now able to treat and rescue a previous DeBakey-1 operation. Very, very exciting technology. More to come on this. And I think this will become more and more upfront as we talk about how we manage the aortic arch at the time of the index operation. This will be one of the many tools that we can use and think about as we do that index operation. Now, is the dual branch endograft for all? No, I think as surgeons, we got to understand and do the index operation. And this is where the team approach comes in. You can really do your team a service or disservice, depending how you do the first operation. You can imagine if the reconstruction of the proximal aorta is not ideal. You can see here in the middle panel, you often see this. There's a severe angulation or kink. Or what I've often seen, a ascending clamp distal with a very proximal ascending graft. These cases will not have the appropriate landing zone for us to rescue using that dual branch approach. So I think education, a team approach, and having heart surgeons understand how their first index operation may have an impact on future options, therapeutic options, is very, very important. You want to set up that first operation nice and long. This is now how all our surgeons here at Penn do our proximal operation. A nice hemiarch that's generous, that the ascending aorta is long, it is not angulated, so that in the future, if this patient develops a need for a rescue, the anatomy is set up for it. And I'm excited that this technology, although right now the focus is aneurysmal disease, I can imagine the expanded indications of how this will be a powerful tool in our tool belt. Arch aneurysms, dissections, proximal endoleaks from a failed TVAR, a failed frozen elephant trunk, et cetera, et cetera. And finally, it may serve as the background, the foundation for a complete total endovascular approach to treating type A dissections. So very, very exciting. As I mentioned, this is just a really good snapshot in the future. This is the Terumo aortic triple branch. I think not in the very distant future, we potentially will be able to treat the arch completely endovascular with all 3 branches accommodated for. So conclusion, it is an interesting and exciting field. Aortic disease is increasingly becoming more common, is a clinically challenging scenario, especially in our aging population. I think the team approach is the ideal platform. We've heard a lot about it, as I mentioned, from the structural heart approach, but I think this applies to everything, including what you have led in the coronary space. I think the team approach is the way to go. And as patient advocates, we surgeons should continue to think about and challenge ourselves and address opportunities, not only optimizing our conventional surgical techniques, but also we need to embrace innovation and novel technology. Well, thank you very, very much for your attention. It's been a privilege to have had this opportunity to speak to all of you.
Thanks so much, Wilson. That was a phenomenal presentation covering essentially the textbook on aortic surgery when it comes to extensive aortic pathology and dissections. I'm going to invite Mark to make a quick comment and a question, and then we'll invite others to please post their questions in the Q&A session, or you can also use the raise hand feature.
Thank you, Munir. Wilson, I completely agree with Munir. This was so clear, so succinct, really a model to be followed with regards to presenting complex data in a really accessible manner, yet really talking about the cutting edge and the future. So we are so thankful for that. I think everyone on this grand rounds really appreciated so much your presentation. I have one quick comment. You know, the big difference, I said there's 4 major areas of adult cardiac surgery: valves, coronary, heart failure, and aortic, right? Aortic is the only one where you don't immediately make the patient better, right? So this is why not only is it the most invasive in many cases, it's also the one you're trying to prevent death, but they don't, you know, if you take away a 7.5 centimeter arch, like the patient's hemodynamic performance is not better 2 hours later, right? So as opposed to valve, coronary, and heart failure surgery. So I think this is also why it is so darn invasive. Apologies for the expression, as you clearly so nicely illustrated, and we welcome your innovation. My quick question is, a couple of years ago in circulation, you saw it. I think you probably reviewed it. There's new nascent approaches of dealing with malperfusion first in type A aortic dissection, often in an IR type of a setting, and then dealing with the ascending aorta later. What's your experience with that, and how do you think, obviously you've proposed other ways to do this, for instance, using hybrid approaches to the arch and descending aorta, but what about a completely separate malperfusion first approach? What's your experience and your take on that? Thank you again.
Mark, thanks for those kind words. And I think you're absolutely right. This is a incredibly interesting field, and it's constantly moving. The malperfusion piece is something that is under a lot of active investigation, as you stated. Patients who present with malperfusion just do not do well. It is one of the highest marker of poor outcome. It's not the extent of dissection, et cetera. It's malperfusion. It's how you present clinically. And, you know, as many of my colleagues have said, by definition, all aortic dissection present with malperfusion, whether it is subclinical or clinical. You just, I mean, it's an aortic catastrophe, right? You're not supposed to have 2 lumens in your aorta. Now, having said that, there has been, as you mentioned, a move in the field to perhaps selecting a subset of populations with malperfusion that perhaps may benefit first from treating their malperfusion before the central proximal open operation. And that group specifically, and this work's been led by the Mission Green Group and the Emory Group in Atlanta, is the visceral malperfusion. We all know those patients do very poorly. Patients who present with ischemic gut, ischemic liver, those are the ones that are close to 40 or 50% operative mortality when you talk about just going straight to the operating room. So here at Penn, we've adopted some of that strategy because we struggle as well with those patients, the visceral malperfusion, the ischemic valve. Those we tend to treat first with some sort of attempt to treat the malperfusion, whether it's stent graft or fenestration. Other beds, other end organ malperfusion, we've been more selective. So coronary, for example, I still think at this day and age, is still operation with open surgery, because I think PCI is probably not ideal in terms of coronary malperfusion. Cerebral malperfusion, that's a tough one. And again, that depends on how the patient presents. Are they in a complete moribund comatose or just waxing and waning TIA? We at Penn are still fairly aggressive in an open approach in terms of cerebral malperfusion. And this brings me to my last point. Some of the new technology that I shared with you perhaps will allow us to even be more selective and have new tools to treat malperfusion. So I foresee a day, not tomorrow, not next year, but 5-10 years from now, where patients with malperfusion may be best treated with some endovascular proximal repair approach, not distal, not in the DTA, but in zone 0, where we know is not the definitive procedure, but it allows us to treat the malperfusion, allows us to perfuse the end organ, and then do a second stage delay open approach. But malperfusion is an area of active active investigation. And as I mentioned, the AMDS device, we think that's going to make a huge difference in terms of malperfusion if indeed the first procedure is an open index operation. Thanks for the great question, Mark.
Thanks so much.
Wonderful. I know we're waiting for questions from the audience. We have about 5 minutes. Vince, why don't you go ahead next?
Wilson, I really enjoyed that talk. Fantastic. Certainly very interesting field. And you touched a little bit on this when you talked about the expertise, about the number of cases done really per center, which is quite shocking, and the complexity of doing cases like this. What are your thoughts, I guess, in terms of building the team on the surgical side, in terms of call scheduling? Do you have your younger surgeons, are they involved in doing these types of endo procedures? You work in a very competitive environment with other hospitals that can take care of patients like this. What sort of moves have you made to try to branch out, to try to educate sort of referral patterns or cardiologists that may be seeing these sorts of patients in the ED?
Vince, thanks for the great question, and thank you for the invitation to speak here today. This is just a wonderful opportunity. You're right, and our healthcare systems are different. In the United States, it's not as centralized as to kindly say it, but it's really it's a different health system. I'll just leave it at that. And the fact that the median case volume per center, not per surgeon, per center is 3, tells me that, boy, there is some opportunities here. And, I'm not going to be able to change a healthcare system overnight. Nobody can. Having said so, when you mentioned what you talked about building the team, I think that culture, what I can do as an educator at our center is to train cardiac surgeons. And this is where myself and some of my aortic colleagues at Penn, I'll be honest with you, have a slightly different take on it. I think every heart surgeon coming out of the program needs to know how to take care of a type A aortic dissection. Now, why is that? Well, because where we are in the United States, it is quite challenging sometimes because of patient access. Some of these patients are in rural areas that will not just be able to get to a center of excellence, quote unquote, in a timely fashion. So what we can do as a specialty to better serve our patients is to make aware and better train our surgeons that they're comfortable doing these procedures and provide tools that will enable them to do the procedures. And that's why I'm so excited about the AMDS device that you guys have had access to. It will now allow a surgeon, maybe not comfortable in doing an extended arch to address malperfusion, the tool to address it in a way that he or she is extremely comfortable in doing, i.e. a hemi-arch. I think, to me, although it may not look as cool, quote unquote, or sexy as a thoraflex, this is going to make the most impact in my opinion.
Coordinator, staff to the front lobby desk, nursing coordinator.
And here at Penn, Vince, I'm very privileged to, and it's quite biased, only aortic surgeons take aortic call, but I know here is a very unique scenario. Most centers probably do not have the bandwidth or the staffing to do that. There are only 5 of us here who do aortic dissections, but we have a large group. So I have to understand and see the perspective of somebody not from an institution such as this. And I know how fortunate we are here. We're very, very lucky to be in a place like this.
Thanks, Wilson. There's a question from one of the panel, one of the audience members, Dr. Quan Chan, who's one of our echocardiography cardiologists. His question is, with aortic disease, the aorta becomes increasingly tortuous, making further intervention more difficult. Thus, earlier intervention might be preferred. So what is your criteria for intervention? Do you factor that into your thinking?
Great question. And tortuosity is a concern. There is a degree of tortuosity that's too tortuous. But fortunately, with most of the devices now that are beyond their first generation, that has been taken into account in terms of design. most of the devices now, and when it comes to the arch, can accommodate a fair amount of tortuosity in the arch. And I think with the right experience, with the right tool, most, not all, but most devices with tortuosity in the arch can be addressed. Now, in the iliac arteries, where you're concerned about access, tortuosity is also a challenge. And we have also made some advances in terms of endograft technology, where there are now low profile devices. You know, we started 24, 25, 26 French. We're down to like 18, 19 French devices. So similar to structural heart in TAVR space, we have made improvement in terms of the lower profile. So all of that together in a giant sort of big picture approach have made tortuosity less, but not completely eliminated, less of a challenge with these new technologies.
Great. Thank you. You know, this brings us to the end of our time. I'm sure the conversation could continue for a while still, and in our subsequent session, we'll certainly do that. But I wanted to take this opportunity, Wilson, to thank you once again for joining us, for presenting to our group on such a complicated and comprehensive topic. I do want to say as a housekeeping item that our next grand rounds will be on June 1st and will be presented by Dr. Luciano Spazzato, who will be talking about brain-heart interactions, particularly with reference to atrial fibrillation. So thanks everyone for joining the rounds today, and thank you once again, Wilson, for joining us and offering your insights.
Thank you for the privilege and opportunity. Have a good day.
Thanks.